Hello everyone, my name is François Cornelis. I'm French, as you can hear, but now I'm working in New York. I was really lucky to start to implant the V-STRUT some time ago, and so we work with Cecile to conduct a multi-center pilot study on feasibility and safety of the V-STRUT implantation. So tonight I'm going to present you some of the results. So this is my disclosures. So the purpose was to prospectively evaluate the safety of V-STRUT for the treatment of vertebral compression fracture and the feasibility of this new technique. And we evaluate some outcomes, but over 1 year follow-up. So I think you are all aware of the technique, so I'm not going to go back to this, and we will probably discuss about later. So it's a prospective clinical trial over 12 months follow-up. 3 institutions were involved, all in France. One was mine at Tenon Hospital in Paris, in the center of Paris. Another was Institut Gustave Roussy, which is very close from Paris and dedicated to cancer. And the last was in Bordeaux, in the southwest of France, where we are working with a surgeon. So the parameters we were recording were the procedure duration and characteristics, the length of hospital stay, the complication, the pain, and the disability. So more or less that's the design of the study. We had several visits, and we were recording what I presented, so patient information, etc., and pain, and we also recorded some images. So this study was conducted from 2019 to 2021. The issue is we had to deal with the COVID. Which it's worldwide, but started in February 2020 in France. And so we were just able to include 9 patients, 4 men and 5 women. Median age was 59. Among these tumors, patients, we had 5 patients with tumors. 3 were osteoporotic and 1 traumatic. Most of them were A1 for the Magog classification, or A3 for 1, and only 3 patients had multivertebral compression fracture, but we only treat 1 level with the V-STRUT. So that's a summary of the location and the implant site. So location was mainly lumbar. Most of them, in fact, we didn't treat above in the thoracic spine, lower thoracic spine. Mainly L4, but L3, L4. For these procedures, we were using mainly the small implant of 5.5 and various lengths depending of the patient, of course. So the technique were like this. So that's a summary of what we were using, and in some case, so we discussed about the location. We didn't, most of them we didn't do KIFO at the same time, but for 2 patients, the operator was doing KIFO at the time. So various implants, more or less 5.5. We use this French cement F20. That's something we could discuss later. With the injection kit system was provided for the F20. In terms of cement, we use more or less what we observed in standard vertebroplasty or kyphoplasty. It's between around 4 to 5 milliliters per level. Duration was depending on the learning curve, and the first cases were we also had some selection criteria among the. We obviously improve our selection. And so that's why the time of the duration of the procedure was longer at the beginning and then shorter at the end. And the hospitalization stay was almost very short, except for one patient. But I think I'm going to show you the case. So, in terms of technical results, the procedure was technically feasible in all patients. No one was excluded. The median procedure time was almost 1 hour. The volume of PMMA was 5 milliliters, which is kind of standard. And we also record in that study how easy was and difficult was the steps, procedural steps to implant the device. And I'm going to show you. So, but it was more or less in 90% very easy. And we only observed 10%, 13 over 128 steps of issues. And this was mainly related to the cement itself. That's why the F20 we used as probably because we were not very familiar with that cement at that time. So that's a summary of what we were using and the steps. And so we studied the guide wire implantation, dilatator tube, etc. Everything you know about the procedural steps. And it was mainly easy and very easy for most of the patients, but sometimes it was difficult. We had some report for the tube implantation, but you know we have that's something with a learning curve. We improve the implantation. So that's a case. But probably tonight we are going to see several cases. So after selecting the adequate device based on the size of the pedicles, we implanted devices. That's another one, and that's the one who stayed very long, not because of the procedure itself, because it went very well, except that it was a plastic bond, so it was quite hard to drill and place the device. But finally, we had to place this adequately. No, the patient stayed because of the course of the disease and was not able to leave the hospital. And a very unfortunate reason is because he gets the COVID at the hospital and stay at the hospital for this reason. That's another case with the procedural steps to place the device, but that was an osteoporotic patient. Quite easy in that case. That's the case I show you just before, the blastic lesion we treated with a V-STRUT in L1, and we had some issue at that time. So adverse events. So we record all the adverse events, and only minor adverse events were reported. And I'm going to describe them. We didn't observe several complications. So that's what we record in terms of adverse events. What is very interesting in our patient is we didn't observe adjacent fracture over the follow-up, which is not surprising because it's very low number of patients included. But it's still something that we didn't observe anything, and that's already a start. And also we observe some improvement in the pain after treatment over the course, and mainly at 2 months and 6 months. Unfortunately, we have with the patient, we had a patient with cancer mainly. That means the location in the spine was not, for some of them were not related to the cancer itself, but osteoporosis. But a lot of them, not a lot of them, half of them died during the follow-up. Just to go back to the occurrence of cement leakage and adjacent fracture, in fact, if we compare to the literature to spine jack or a KIFO or Kiva, etc., in fact, the numbers are quite similar for cement leakage. and we didn't observe any adjacent fracture after. But obviously the number is different. One thing that we could report is if you already used V-STRUT, try to not remove the V-STRUT by forgetting to dislog the device of the instrumentation, because it will come back with the cement. It's nearly impossible to get it back. So that case illustrates this is fact when the instrumentation was removed, the V-STRUT came with this. So that's the issue we observed. The only issue, it was nothing happened to the patient. He was not complaining about anything, but that's something we should avoid. So just the outcomes was the hospital stay was 2 days. We mainly did this as inpatient. The disability improved over time, but this patient had mainly cancer, so there are other comorbidities, and it was not very helpful. But I mean, we still saw some improvement. So that's the pain. So we observe a significant decrease in pain. That's a good thing. That the outcomes, so I already mentioned this, and most of them were discharged, but some of the patients died after due to the course of the disease. So key messages for this very small prospective study. So we didn't observe serious safety issue with the device, only cement leakage and no pedicle fracture or adjacent fracture. So we remain in the standard of the literature. We had the issue with the cement, so that's something we improve over the time. And I think now there is, I think we are managing better than what we did before. That's already something. And the implantation was quite easy, and we obtained some effect with the reduction in pain and improvement in function. So that was the goal of this treatment. So that's great. So the limits of this study was very small size. It was in France. We were starting with the implantation of the device. Very short follow-up. We had patients who died during the follow-up. So that's an issue to record and monitor all the parameters. We had issue with the COVID. That's seriously impacting the inclusion and the follow-up of the patient. And we didn't compare to any other techniques. So in conclusion of this study, the implantation of V-STRUT appears feasible and safe. We obviously need larger and comparative evaluation. And so I think I would, as first implanter, I would be very happy and excited to see the results of the procedure performed here in the US. And that, it's very promising. Thank you.
So I decided to change based on discussions with colleagues and musings at meetings where we were frustrated and wondering why we kept on having these adjacent fractures or refractures at the levels that we're treating. And I was talking to a colleague from Europe, Alessandro Cianfoni, who published a lot recently on the SAFE technique and his similar frustrations in these large lytic vertebrae, or these vertebrae that have fractures at the base of the pedicles. And it made a lot of sense to try and find a system that gave reconstruction of the anterior middle column, but also the posterior column, which is missing from everything that we do. We don't have percutaneous screws in the US. We don't have open screw systems that the surgeons do. So I was looking around the literature and I came across V-STRUT and the system that was being used in fractured neck of femurs. And it made a huge amount of sense. So I actually reached out to Cecile some time ago to look into the device. And that's why we brought it on at Mount Sinai. And we're going to talk a little bit more about what we've done with the device, but also how we're moving forwards with a clinical trial as well. So we'll talk a bit about the biomechanics and cases, or specifically a case with a description of how we do the procedure, and then the study, which is called Reconstruct. So everybody knows about the device. Most of us have probably done the training, but it's indicated from T9 to L5. It's indicated to be used with PMMA, and it's a 510K device, as you said, based on predicates, and that was Kiva. It's a peak polymer, so it's not metal. It doesn't behave like titanium. It has the ability to absorb flex and stress, which is important, and it comes into some of the reasons why I think hopefully it's going to prove useful in preventing adjacent level fractures and restoring some normal momentum and movement to the spine in these osteoporotic patients. But essentially, it's indicated at this stage for Gennett fractures that are grades 1 and 2, so not severely compressed, not the vertebraplanar fractures, but ones that have superior or inferior end plate deformity, leading to less than 50% of fracturing at the level. Sorry, we're jumping across a little bit. So the biomechanical principle, it's a peak polymer. It's closer to normal bone in terms of its strength and flex than titanium is. It gives pedicle anchorage, and the idea is to share load between anterior middle column and posterior column. And again, the idea is for this 360-degree reconstruction, which is more physiological, it's anatomic, and it's what I think we should be aiming more for in the treatment of these patients. And why is that important with aging? Normal spine, the distribution of loading is roughly 50-50 or 60% anteriorly, 40% posteriorly. But with age and loss of trabecular mass and more kyphosis, you get a decrease in the posterior loading of the spine and an increase going through the anterior column, which I think comes to a bit of a debate and discussion as to why these patients fracture adjacent levels after treatment, especially if they have significant deformity from their kyphosis. And the intent is for this device to rebalance that load to the posterior column. So Cecile and Dr. Hambly and myself have just recently published a paper which has only just been accepted by Clinical Biomechanics, I think. It's not available on PubMed yet, but hopefully it will be soon, looking at a finite element study to quantify the redistribution of force through the vertebrae. And this is the findings. So as we said, peak material reduces the stress in the treated and adjacent vertebrae. And that was the finding from this experimental model, when part of the applied stress is actually transferred to the implant and offloaded from the adjacent vertebrae above, but also the vertebrae in which it's been implanted. And when you compare that to things like titanium, and I'm not trying to pick on SpineJack because I've used SpineJack and I still use SpineJack. I think it's a good device, but I don't think it's quite the answer in solving the problems. I think it's a good device for a specific kind of fracture, but I don't think it's the only device that we really should be looking for, or the momentum in terms of device development should stop there. And obviously, titanium is far, far harder than healthy bone. So the load stress is transferred to the upper vertebrae. And that is one thought of why you get adjacent level fractures, at least from an experimental model. If you look above here, just on the heat map, the center pane is the V-STRUT with the peak implant. You look at the color map or the heat map, the adjacent vertebrae, comparing it to a titanium pin versus a normal vertebrae. And there's, a fairly clear difference. Going to move on. So what's the experience so far in the United States? And this may have changed recently. There might have been 1 or 2 more cases, but there's somewhere in the low 20s worth of cases, most female, which we expect, as opposed to Francois' case experience in France. It's vastly more commonly to be osteoporotic rather than malignant. I think that there's probably a little bit of a reticence, at least initially in the United States, to put an implant into a patient with cancer. So that probably explains why there's been a slow uptick on that. But specifically at Mount Sinai, I think we started using the device in January of last year, or February as our first case. We've done 7 procedures, and we've been really quite cautious in who we're using them in, making sure that they're on target, on label in terms of fracture classification, but that there's pretty clear space and size within the pedicles for access. And if it's borderline, then we're not using it. And to be honest, that's probably being a little bit conservative, again, based on our experience from using things with like SpineJack with larger access devices. So far, we haven't had any procedural complications. We have experienced some perioperative discomfort at the soft tissue access sites in the back, one with expected things that you're going to get, which is going to be slightly more, obviously, than if you're just using an 11-gauge jam sheety on one side. We've had 2 patients with disc cement leakage. And with this device, if there is a cleft or a fracture going to the end plate, then it is going to the cement's going to travel down the path of least resistance. So it takes some technique in avoiding that. We've had, of the 7, 1 adjacent level fracture, and that was in a patient that had cement leakage, where the cement leakage into the disc was more anterior, so in the anterior half of the disc, and morphologically it wasn't sessile, it was more of a pointed aspect of cement going up and coming close to contacting the inferior plate, and that patient went on to fracture that level. And in retrospect, most of the time in my patients, if I think that they're a high risk of adjacent level fracture because of that die punch effect, I'll usually go ahead and cement that level just prophylactically. And that's something that I think we should have done in that patient. This is the one case that I want to show, and it goes through a little bit of the technique as well. So it's standard kind of fracture. This is an L1, I think. It's an A1 junctional level fracture, again, at grade 2, just over 25%. There's no pedicle involvement. There's no retropulsion. The canal's nice and normal in length. Patient had quite severe pain. It was a 4-week-old fracture, but the patient presented to the emergency department and needed to be admitted for pain control. So in those patients, if I feel like we have a really good system set up through the emergency department, if a patient's presenting with a compression fracture and they're presenting for pain control or tolerance of pain failure as an outpatient with narcotics or simple analgesia, then that's failure of conservative therapy. And those patients, in my experience, typically bounce back. And if you take them and follow them up in clinic, then they usually will come back anywhere between 2 weeks to 3 months later. And if it's 3 months later, often their fractures are now quite comminuted and collapsed and much, much harder to fix. So we've tried to circumvent that by early intervention and early follow-up. Just the basic early films, straight APs and laterals. You can see the wedge. Okay, so this is how I typically do the procedure, similar to spine jack. So I do it down the pedicle view. I measure the pedicles. I take a jam sheety and take it down the pedicle to the pedicular somatic junction, swap over for a K-wire, and then drill the holes, upsize the drill holes, and then measure the device, insert the device over the K-wire, and then cement. Just repeat the same process. I use a cross-targeting technique down the pedicle to try and make sure that the devices are going to meet in the midline, similar to using a transpedicular ablation technique for tumor and as well. And this is one of the patients where there was cement. So, sessile, small volume of cement, not getting anywhere near the disc, not anterior, so we decided not to cement. And then the final pictures. She did well. She ended up with good pain relief when we followed her up at day 14, so down from 8 to 4. Unfortunately, since then, she hasn't come back to see us yet. So, and that was, I think her case was performed last October. So moving on. This is the clinical study that we've partnered with High Prevention for out of Mount Sinai. It's called V-STRUT. It's a prospective pilot study based in the United States, focusing on osteoporotic fractures primarily, but you can enroll malignant ones. It's 4 sites, of which we have 4 selected centers, Mount Sinai being one. We're the only active enroller at the moment. The other ones are going through VAC process and IRB setup. And we have 2 patients enrolled. The inclusion criteria is standard inclusion criteria that you'd expect for most trials, and these have been largely piggybacked off the SACOS study with the intent to hopefully enroll quickly, get some signal from the data, and then move on to a pivotal study and potentially use pre-existing data as a comparison arm. And you could do that with Markov modeling and hopefully avoid something like an RCT. These are the included types of fractures that we're keeping. So A1s, A2s with sagittal and coronal clefts, and partial burst fractures, A31s. At this stage at Sinai, we haven't done any burst fractures. We haven't had any cleft fractures. They've all been A11s to 13s. And this is the standard of follow-up that we're keeping to the study, and this more or less mimics what we do in clinical practice at Mount Sinai, and you can see that by all the standard of care. So CT scans at 6 months, CT scans at the treatment date, usually by a flat panel or cone beam CT, VASs, Westry, EQ5D, Roland Morris, and sequential imaging follow-up with scoliotic series. So we're trying to be as complete as possible and bounce from that into a larger pivotal study with some luck. I'll leave it at that and pass on to the next speaker.
So Francois and Reed and Cecile, thank you so much for allowing me to be a part of this. My name is Dr. Neil Curran. I'm an interventional radiologist at VIS in Siouxland. Siouxland is an area in the Midwest spanning over across 3 states, South Dakota, Nebraska, and Iowa. I've been doing vertebral augmentation for about 7 years, and probably an N of somewhere around 300 to 400. I really lost count, but obviously I'm very passionate about intervention in this arena, given that there's a lot of players, whether it be neurosurgeons, interventional radiologists, or pain specialists performing these. And what I simply was attracted to is this is a elegant evolution of what already exists. Most of us, as Reed was saying, who perform vertebral augmentation will find this very similar to SpineJack or any other device that's out there. But I think what the future holds is that stabilization that we're all so curious to know clinically. Will it make a difference? Will it reduce adjacent level fracture? And in my anecdotal experience of 3 cases, I'm seeing promising results. You have to understand, not being at an academic institution, I'm limited to sometimes where the patient might get their imaging from. I'm limited, by maybe low quality MRI per se. And I'm also limited as far as the knowledge of the referring population there. So I receive fractures sometimes very late. They're partially healed. Sometimes there's more wedge deformity than I would like. And you can see the progression if there's 2 MRIs back to back in a month that the primary care had ordered. It kind of leaves us in a place where we haven't optimized that chain of command like you would see at Mount Sinai or any big institution where there's a fracture and the appropriate people are called immediately. So I just think my participation in this talk is more for the folks out there who may not be at the academic level, that you should definitely have your eye on this as an option, because it's very doable if you do vertebral augmentation, and the results so far have been very good. So I just have 3 cases, and I don't have much written on the screen as far as words go, but there are a lot of pictures, and I would hope at this point Cecile can help field questions during these cases, because I would like an open discussion. I'm sure a lot of you have experience in this field and can offer advice or comments on what you're seeing here. So this was the first case we did back in October. It was a male, which is kind of the minority of the patients I treat. But then again, he did suffer a fall. I did not have a DEXA scan on him, but this fracture had been kind of brewing for over a month, and he failed conservative therapy, and came to me. Actually, a neurosurgeon sent him to me, and I considered just doing vertebral augmentation. The deformity there was not too wedged where I even considered using something like SpineJack. I was just going to do a kyphoplasty. But his pedicle size were adequate, and it was a good case to test the product out. And so basically, again, I'm not going to belabor the procedural part of this, but this was done in my office. I have an office-based lab. We have a Siemens floor-mounted unit. It does have DynaCT, so it has cone beam CT. So if at any point, if we ever felt that we needed to check where we were, we could, and that's a luxury. Of course, any of you out there who don't have that on your fluoroscopy units, it's not necessary, but if you do have it and just haven't used it, this is a great case to do that. Even in the planning stages, if you're looking at the MRI and you're saying this is going to be a great case for this, and you put the patient on the table and you can't get that perfect lateral, and you just, the visualization, maybe the patient's obese and you can't really see very well, doing a cone beam CT can have you just measure those pedicles. And at that point, if you feel they're not large enough to accommodate the device, you can just go ahead and do traditional kyphoplasty. So in this case in particular, the cement, we did use Stryker cement, Vertiplex HV, and we did not get a crossfill. And, I'm obsessive about that, maybe a little too much, but it's one of those things. Are we treating the patient or are we treating the picture? And at the end of the day, we were very happy that there was an extravasation. We did get maybe a little bit of some cement in the pedicle itself, but we weren't too worried about that. You can see that right over here on the AP. And he had a follow-up. He did great clinically, by the way. So he came back about 3 or 4 weeks later in clinic. He did wonderful. He was pain-free, and he was very, very happy. This gentleman took another fall and had pain. And of course, it was a trigger reaction to get an MRI by his primary, given that he had already fractured once. And the picture on your left is midline. And as you can see, the original fracture over there at L4, there's still, this is a stir image showing edema in that mid portion. And you can see the new fracture there at L1. If you look laterally, you can see the cement fill in our treated region, and then you can see his new fracture there. Now remember, when he followed up after his original treatment, he was pain-free. So all his new pain, and on examination, his pain is in the higher thoracolumbar region. But it was nice to get the MRI, because here we are doing our first case, and now we have an MRI follow-up. And one thing that's really nice as a radiologist, and I'm sure for any neurosurgeon out there who's looking at MRIs, this is the actual peak polymer in the pedicles, and you can tell it has no blooming artifact. There's no gradient artifact from metal. So it's just something to think about. You know, the device itself doesn't cause any artifact on future MRIs, which is really, really nice. Over here in the middle, you can see our device through the pedicle. Second case, and let's mention also that on this first case, that adjacent level fracture, you can tell these L5 and L3 are intact, and he in fact fractured L1. So with a fall, his L3 and L5 appear to have been protected. So for our second case here, it was a 63-year-old female. She has maybe, mild to moderate biconcave compression of L3. This was a very straightforward case. One thing I did notice is, because of her lordosis and just the way I could get into her pedicle safely, I wasn't able to come as parallel as I could to that end plate. But at the end of the day, if we look at the biomechanics of what we're trying to achieve here, I mean, we're just transmitting those forces through the vertebral body posteriorly. And so even with this access, I was still happy to proceed, and I felt it was safe to do so. In here, and I think, Reed, you probably were looking at this and saying, you didn't get those exactly midline as mine, but I did notice that too. And there is a learning curve with the device. But at the end of the day, this patient did exceptionally well, and clinically, she did great. Our third case over here, this is one I would kind of wonder if anyone in the audience has commentary on. This is a very advanced fracture over here at T11, I believe. I'm sorry, T12. And if you look right above at the anterior inferior margin of T11, there is a little edema forming. And this is one where I said, if I'm going to treat T12, I'm going to treat T11 as well, because that's going to fracture eventually. I also treated L3. So I did a 3-level case. And which device out there would people use, let's say, for any of these levels, for 11, 12, and 3? Just to have some audience participation here, if anyone's, wants to take any comments out there on what you would use for this. Okay, well, if you have it in your head of what you think, what I did was I did a traditional kyphoplasty at T11. I did a spine jack at T12, and you can see one of the skis is popping out that lower margin of the inferior end plate. But she did fine, and I did a kyphoplasty at L3 as well, and she did very good. 2 weeks later, she fell out of her wheelchair at her nursing home, and this lady's bones were like soft as butter. I mean, she is osteoporotic, and this was the true test. When she came back with new back pain, and we MR'd her, and these are the type of images we get. They're low magnet, 1 Tesla images. They're not that great, but she clearly has a new fracture underneath the spine jack at L1, and that's what we had to treat. So we measured her pedicles up, and luckily we did have a CT from about 4 years ago that I used as a reference because the MRI quality wasn't too great. I would say the resolution of that is probably within a millimeter, but I wasn't confident to say that her pedicles were exactly that. So luckily she had a CT and it looked adequate to go ahead and proceed. So now we have a picture with T11 with our kyphoplasty, T12 with our spine jack, and L1 with a V-strut. And cement distribution was very nice. I was very happy with the way these deployed. By the time we got to the third case, I say the procedure time was probably around 35 to 40 minutes, maybe 40 minutes, I think, once we got all our ducks in a row. So that's my takeaway coming from a community doctor who does high volume vertebral augmentation, is that I believe this device is useful for stabilization over height restoration. And I think what we need to know is, looking forward with the studies that are coming out, is that stabilization going to have a better clinical effect in the long run? I know that's height restoration is very attractive from an imaging standpoint, and it looks great. And of course, restoring some kyphotic deformity in patients, I'm sure it has its mechanical benefits. But this is an elegant evolution of a procedure that already works. So I'm excited to be using it, and I'm excited to present these 3 cases to you. Thanks for your time.